I'm Tamara Thomas, editor-in-chief of UrbanHealthToday.com, part of the DocWire family of medical news sites, and I want to thank you for tuning in to Urban Health Weekly. Our goal each week is to keep you informed of the latest in health and medical news right from today's headlines. It's time to empower yourself with open conversations about your medical care with news that matters to you. So are you ready? Let's get started. Hi, I'm Tamara Thomas, and welcome to Urban Health Weekly, where we talk about medical news and health topics that matter to you. I'm here with Jackie and Lou. How are you guys?
Hey guys.
Well, here.
Good over here.
All right, awesome. So on to medical news of the week. This just in, the FDA moves to ban sales of menthol cigarettes. I know we were doing something like that similar here in New York, but now it's
they were already banned. I didn't even know that's still like a thing, huh?
Yeah, exactly. That's kind of what I was saying. Like, I thought we did that already, but
yeah, I thought that was like 10 years ago.
No, this is no. This is to remove menthol from cigarettes. So what I heard,
said it's been getting discussed for so many years.
Well, yes, it had been discussed for many years because it appears that the science is saying that about 85% of people of color, Black people, smoke menthol cigarettes, and that if the menthol was taken out of the cigarettes, that less people would smoke. I don't know if I buy that, but Lou's got to be in his bonnet about that one too, so we'll discuss. Anyway, the Food and Drug Administration announced the plan to ban sales of menthol-flavored cigarettes in the United States, a measure many public health experts hailed as the government's most meaningful action in more than a decade of tobacco control efforts.
Wow.
Yeah, a decade. The proposed ban is expected to have the deepest impact on Black smokers, nearly 85% of whom use menthol cigarettes, compared with a rate of 29% among white smokers, according to a government survey. If effective in reducing smoking, the ban could significantly diminish the burden of chronic disease and limit the number of lives cut short by one of the most hazardous legal products available. The proposed ban would, among other things, improve the health and reduce the mortality risk of current smokers of menthol cigarettes or flavored cigars by substantially decreasing their consumption and increasing the likelihood of cessation, the FDA Commissioner Dr. Robert Califf told the Senate committee Thursday. Menthol is a chemical derived from the mint plant that can also be made in a lab. It is included in cigarettes to make smoking less harsh, providing a cooling sensation in the throat. Public health experts say menthol cigarettes have been heavily marketed to Black people to devastating effect. African-American men have the highest rates of lung cancer in America, according to the Centers for Disease Control and Prevention. Now, Lou, you had to be in your bonnet about this. I'm going to let you have the floor.
Okay, a couple of things. I mean, three things. Number one is, why don't I just ban them? Cigarettes. Why?
Because you can't tell grown people what to do. This is not prohibition.
You certainly are. You're telling them they can't use menthol cigarettes. So you are telling grown people what to do.
Aren't they telling the grown manufacturers what to do?
Well, what they're trying to do is say, well, you're using menthol, so if you use the other brand, maybe you won't like the other brand, and maybe you'll slip, maybe you'll stop smoking or that. I mean, look, if it's no good, it's no good. It's like during when they had prohibition, which was a bad idea, but when they had prohibition, it wasn't like, whoa, let's ban vodka flavored, orange flavored vodka, but regular vodka is okay. No, it's not okay. If you feel that, and I'm not saying that it's not a good idea to ban cigarettes, I think it's a great discussion to have, because obviously a lot of life minutes and a lot of life years are wasted with cigarette smoking, including dollars, including, people that should not be sick are sick. So my feeling and budget goes there. There's dozens of reasons why cigarettes shouldn't be smoked. However, if you're gonna ban it. Don't play around with it. The second thing is you're making an assumption that people are not just gonna say, hey, let's go from menthol to regular, even though the taste is crummier. But you know what? The flavor, it's kind of like when I went from soda to coffee. I needed my caffeine, and I was going to have my caffeine in the morning, so I just switched poisons. These people go switch poisons.
Yeah. So in other words, you're saying, well, what does the flavor have anything to do with it? It just makes it taste fresher.
I would say,
well, it makes it more tolerable.
Yeah. What I would say is let's put bans on how much nicotine can be in a cigarette. How about that one? Let's start with a non-race-based, health-based feeling as to where we're going to go with this.
I mean, that's a good point.
I remember when I was, did you guys ever try a cigarette in your lives? Like, did you ever? Like,
when I was a teenager, yeah.
When I was a teenager, I went to Six Flags and I bought one of those novelty things. They used to have that, like, in case of emergency, break glass, and they had in there. And I was like, wow, I have no adult supervision. And I went in and I bought this like little, novelty thing, and I broke it open, and it was a menthol cigarette in there, and it was a cool, remember, like that. And I remember being like, hey, this isn't that bad. It's so tasty. Like, and normally I would have been repulsed by like that flavor, but that menthol was a little bit, it did make it, tolerable. But aren't they just going to move the menthol? I mean, do they have menthol in like vape? Do they have menthol in other things? Is that just
probably, yeah, but I don't know if this includes removing it from vape as well. They haven't said that. I don't know if it's a good, well, so my thing is this, it's just like what the alcohol industry did with their drinks. They realized there was a certain part of the market who didn't enjoy the disgusting taste of
so they make it delicious.
So they made it delicious and sweet, and they increased their market share. Now, if the government turns around and says, you have to take the sweet out of your drinks, I bet you that market share is going to shrink. Now, people are just going to find other ways to get their, intoxication on. Like, look, at the end of the day, people want to be intoxicated one way or the other, whether it's by cigarettes, or everyone has their vices, whether it's sweets, whatever. I'm just saying that the hope is that by taking the menthol out, that more people will be like, ooh, yuck, this doesn't taste good at all. But the menthol blunts the tarry taste, and that's why people can tolerate it. And once that's gone, maybe some smokers will give up the habit. I mean, that's the hope. I don't know if that's actually going to happen, because at the end of the day, it is an addiction. And people tend to not so easily give up their addictions until they're actually ready to. And I don't know that it's going to be by some government edict that says, take the flavor out of cigarettes. So you're right there. But as far as saying, well, ban cigarettes and all that, then you got prohibition all over again. And then people are going to be, doing all kinds of underground stuff to get what they want, just like cocaine. Cocaine is not legal in this country. And yet everywhere you turn around, people got cocaine. That's not good for you, but so you can't really stop people from doing harmful things to themselves. It's just our nature. They're the only species, by the way, that seeks out this kind of toxic ways of entertaining ourselves. But that's another another matter.
Yeah, but hear me out on this. I'm just laying out the options. I'm with you. If I had to choose, I don't think that we should ban cigarettes. If people want to do something, I think they have the right to do it. And I think
but you're right, there is a sort of infantilization going on. Like, no one's putting these cigarettes in people's hands. And you know what? Do something about the marketing. Maybe don't get them to start smoking to begin with.
Well, they have done, they've prevented.
But once the horse is out of the barn.
They prevented cigarette ads on TV. They prevented them on
in magazines.
Things like that. But the true addictive part of a cigarette is the nicotine. Scientifically, this can be monitored. It can be looked at, and all of these things, all these things are preventable in terms of that. So I can see an edict that the FDA says, let's make the cigarettes have only blah blah nicotine in them, or minimal nicotine, or no nicotine. I'm sure they can figure out how to do this. But
wasn't that the big argument that took place years ago with like that movie, The Insider? It was that they manipulated the levels of nicotine.
Yes.
They adjusted it, and they viewed cigarette as a vehicle, as a
Right.
as a nicotine vehicle. It
Right.
was purely for that.
Right. So take out the addictive qualities in cigarettes that are artificially put in there. I can see the FDA getting behind that, and I can see the FDA doing that.
So you think this is an empty gesture then?
No, I think there's a political gesture, just showing and saying, oh, look at how we're saving X.
Look what we're doing.
Look at what we're doing for you, but not for you because we're treating. No, the FDA's job.
So your issue with it is the reason that they're doing it? There's things there in those cigarettes that cause addiction. Period.
Mm-hmm. They're not even touching that.
It's a false flag.
What are you doing? I mean, if you want to regulate the sale of cigarettes because it's dangerous, which is what they're doing, look at what is the real danger. Yeah. The real danger is the addictive qualities, not the menthol, not the taste. These people are addicted. The menthol is only going to have them switch. Maybe a few, maybe 10, 20% of the people that are doing them are going to drop out. But if not, they're just going to convert.
Well, some people, when the price of cigarettes, when people couldn't buy Lucy's anymore and they had to buy whole packs and the price went up, some people did give up. They were like, it's just too expensive. I can't.
That you do hear a lot, that people are like, the price is so high. It was the price that made me quit.
Yeah.
Yeah. So
it's another, I guess, another nail in the coffin, so to speak.
I went, the first thing that I did when this was announced is I went to the stock market and I saw what was the effect of Philip Morris.
You have Philip Morris in your, you have.
No.
Oh my God. Philip Morris.
No.
He has in his portfolio.
How dare you?
Dare you?
Well, you brought it up.
No,
you would not have brought it up if you hadn't had it in your portfolio.
I wanted to see how serious this was because to me, the stock.
You wanted to see what this is going to result in.
So if they banned iPhones, I would go onto Apple stock and say, okay, what's the effect here? What do people, what's the smart money say? Actually, the Philip Morris stock went up.
Really?
Stockpiling?
No, they're laughing right now. They're laughing. Because they're saying, okay, they banned menthol. These people are just going to switch. They're scientists. These people have more data than we can have here.
Right. What other tweak can we do to make it more palatable?
These are companies between Philip Morris and Philip Morris International. You're looking at market capitalizations of close to $1 trillion. They're throwing RJ Reynolds and throwing British Tobacco and all those companies. And that's the first thing I did. I said, okay, let me see what the cigarette stock's doing. They actually went up. And why did they go up? Because they realized this is an empty gesture. This is not going to hurt sales.
Okay.
It's going to flip over. So what is going on here? It's a gesture.
So it's political pandering then.
Absolutely. In my mind, look,
making sure you look busy.
Exactly. And I'm a little surprised at the FDA.
Are you surprised at the FDA? Really?
They become so political.
Yeah.
And I think we saw that maybe
high fructose corn syrup is generally regarded as safe. Come on.
Yeah. And
it's in everything.
Yeah. So there you go.
All right, you have made your point. I see what you're saying. It's kind of like it's a bit of political pandering. It doesn't really do anything. I don't know who these scientists are that presented this to the Senate committee. Oh, this is the FDA commissioner.
Yeah, the FDA.
And where'd he get this literature from? African American men have the highest rates of lung cancer in America, according to the CDC. So this is the CDC. Okay, need we say more?
More political.
Listen, I think, sure, why not? But I see what you're saying in terms of like, okay, so you're only doing it because you want to save Black lives. What about other lives?
They're not saving anybody's life.
I know that, but the way they're positioning it is, 85% of menthol Black smokers are menthol users, and this may save those people's lives. Well, how about some, anyway, let me not get political. Well, but I smell what you're stepping in.
I would say if you want to save lives, which is what you should be doing, look at the nicotine content in cigarettes and pass legislation.
Yes, get your own scientists. Get your own scientists into those labs.
You're going to save white
lives,
out exactly black lives, all lives.
Find out. Oh, don't start with that all lives matter stuff.
Oh, is that a group?
Don't no, but that's what people say to dismiss the Black Lives Matter.
Oh, I'm sorry, I didn't.
All lives matter.
I didn't. It wasn't.
They should change their name to Black Lives Matter too. But
I think it should be called No Nicotine. If you're really concerned and you really want to do this, bar the addictive qualities in cigarettes. That's where they should go, not the flavors. Not because these groups like one and the other. Yeah, get out of here.
I agree. Well, yeah, it's an empty gesture. I get it.
Yeah. I want an argument. Is this a special?
Your point is taken. Don't gloat. Just
denied again.
I win another one again.
Take the W and move on. Speaking of high fructose corn syrup, colorectal cancer rising in younger people. 34-year-old TikTok star urges young people to get screened after colon cancer diagnosis. Ow. TikTok star Randy Gonzalez, who was the father behind the Enki Boys, shared on his account that he had been diagnosed with colon cancer more than 6 months ago. It's the same type of cancer 43-year-old Chadwick Boseman, who is famously recognized for his iconic role in the movie Black Panther, was diagnosed with. 6 months ago, I got diagnosed with stage 4 cancer. Stage 4, he said on TikTok. I kept it to myself and I felt like it was selfish because it was personal. But I felt like I can use my situation to give awareness to young men like myself. So he's only 34 and he was told by doctors it's very rare for young men to be diagnosed with this type of cancer. In fact, medical professionals across the country are seeing colon and colorectal collectively, cancer rapidly increasing among young people. There is an epidemic of younger patients being diagnosed with colon cancer under the age 50. Anton Bilchik, MD, PhD, surgical and oncologist, chief of medicine and director of gastrointestinal research program at the St. John's Cancer Institute at Providence St. John Health Center in California said. Overall, we're expecting about 20,000 new cases among young people under 50 this year in the United States will be diagnosed with colon cancer. For Gonzalez, he was experiencing pain in his upper abdomen, and his wife then suggested he get a colonoscopy, where he later discovered he had colon cancer. At his current stage, he said he has 2 to 3 years to live, but with chemotherapy treatment, he is expected to have 5.
Oh my gosh, and he's 34.
Yeah, although the exact cause of colon cancer is not known, it's important to recognize the symptoms and signs of this type of cancer, no matter your age. Oh, wow.
Wow. And his wife was like, why don't you go he wouldn't have even gone, maybe not without his wife making.
No.
Wow.
But let me just say, I'm so glad that he's using his platform to
encourage
young people to get tested and to think about their colon health. Because let me tell you, Chadwick Boseman's death shook the Black community in a way that it's reverberating today. And I hope this guy, is going to have a similar impact on young people and get people to take their health seriously.
I think we've got to, and I'm saying we as a society, not we as us three, have got to start looking at this new emerging trend of colon cancer striking people, 20 years.
Young people.
Yeah, young people. And what is it? Is it food? Is it lifestyle? Well, it could be lifestyle, sedentary lifestyle that,
it's all of those things. It's the food, it's the alcohol, and it's sedentary lifestyle. Look, it's the fast, I'm not going to exercise, I'm going to have surgery lifestyle.
Yeah, I don't know what it is.
I bet it's the processed food lifestyle.
Yes, yes.
And much like, it's a story that I think I told on the show before, where with American Indians, diabetes was also almost unknown. And once they went to a Western diet, their numbers went up
call
higher.
They call it the white man's disease.
Yeah, they went up higher than anybody else. And it was just because they weren't used to that. Their bodies were genetically not used to this type of stuff. I mean, maybe our bodies are just not genetically modified to eat, I don't know.
We're not. But you know what was interesting and I read a couple of days ago? I read that Asian women that live in their native countries, their rates of cancer are very low. And then when they come to this country and adopt the habits of this country, their rates for cancer become the same as other women in this culture.
Wow. We've been saying that too, though. Hasn't that been going on? That as soon as like any country starts adopting that Western diet, it just, suddenly obesity creeps in, diabetes creeps in. It's just, it's a disaster of a diet.
And it's also linked to poverty because, studies have also shown, longevity versus that. So if you're able to afford organic foods, if you're able to afford.
But this guy's not a poor guy. He's got like this Inky Boys has got like 1.5 million.
Well, yeah, but
I'm sure they're making good money.
It doesn't mean that that he's eating healthy.
Okay, but then say that. But I agree with you on the poverty front.
But he just became rich now. He had 20, didn't he have like 20 years of poverty and then
where'd you get that from?
He was rich all his life.
I don't know if he was rich all his life, but
well, you just said he had money.
Well, yes, he has. He's a TikTok star. He has the popular...
TikTok has only been here for 3 years.
Okay, but
because you're a TikTok star now, he if he's 30 years old, he had 27 years of lifestyle A and
27 years of maybe not the best, maybe processed food. Who knows?
Right. Yeah, what I'm saying is that, now with inflation and God, I hope this is not getting political, but, you can really see the differences in how people eat. I mean, when you go to a supermarket, half a cart is now $200.
Yeah, I really noticed the difference of that in the last few weeks. And the price of food is woof.
And how is somebody, how is somebody going to live? And, okay, so now I can start people are going to start making choices, I think, at the shopping cart level. And those choices may not be healthy choices, is all I'm saying. When you're doing your shopping, you should kind of be bank account agnostic, where you're saying, okay, I want to buy the best avocado. Not I want to buy the avocado.
But a lot of people don't think like that because a lot of people don't realize that there's difference. A lot of people think like that organic is like a hoax. It's there's no difference, that it's equal in quality and it's just more expensive for no reason. Like they don't really fully understand that there is an intrinsic and extrinsic difference in the food, the way it's grown.
Then they should go back to our show.
Yes, the show with the Dirty Dozen that you talked about. Yeah. That was helpful.
But a lot of people just don't know from when. I remember one time I was at the supermarket and I was buying some cheese. I'm ashamed to say, but I was buying some cheese, and I was making sure I got
What's wrong with cheese?
Well, I'm not really supposed to be eating cheese, but I got organic cheese. And these two women were standing next to me and saw me taking the organic cheese, and they were about to reach for it. Then they saw the price and they reached for the regular cheese. Mm-hmm. And right there, they were just like, it's no difference. We're just going to get this cheese and save money. Right. And, they probably looked at me like I was silly for spending all that money.
Privileged person, you.
Right. Or an organic cheese. But it's because people really don't fully understand. Like they understand on a basic level that organic is better, but they don't know why it's better. Mm-hmm. And better doesn't mean to them that the stuff that they're choosing is bad. You see what I'm saying? If something is just better, it's like you can shop at Target, or you can shop at I guess Forever 21 or something like that, and you can get fast fashion clothes, and you can look nice. Yeah. Or you can shop at a higher end shop and look really nice. Mm-hmm. And most people choose to just look nice. right? And I think people see food the same way. They don't see it as harmful. They don't see
They
it
might be seeing food as luxury as opposed to
right,
healthy and necessity.
right. But they're not thinking about food as information, where food is going into your body and your body is your temple, and you have to be careful what you put into that. Like a lot of people don't understand that. And so that's what goes into the choices they make. It's like, oh, don't be ridiculous. I'm not going to spend that much money. This is just as good. I told you about that woman who was preparing the food on the
oh god,
was that TikTok, that video where the woman was preparing food and she was
Well,
like,
I
just use any old
oil,
any old oil,
Yes,
any old
yes.
rice, any old, and she was just throwing, but her nails look gorgeous, you know.
Right.
And so that's what I'm saying, is that people don't like prioritize that because they don't see the food as harmful. They just see it as it's just as good.
They're not seeing what you've been talking about, which is
Right.
that
They're not
food is an investment in your health.
Right. Because on the back end of years of eating like that, you have extreme medical bills that you can never dig yourself out of. So
Right.
you know, it's like, what is that term? An ounce of prevention, a pound of cure.
Yes.
You know, people are not taking the ounce of prevention. They're not seeing it as an ounce of prevention because it's expensive, because it's hitting their pockets now. But they're not thinking about, on the flip side of that, how much money they're going to have to spend on healthcare, if at all.
Right.
You know, some people just go straight to buying the plot, like, well, I can't afford this. I got cancer. I can't afford this. I'm just going to buy a plot and just live out my years. So it's just something to think about. Like, some people prioritize, like they'll go to the Nike drop or whatever. I'm dropping brands like crazy, but my point is, I'm talking about brands that, you know, are recognizable so people can understand what I'm trying to say. People will not settle and say, wow, these Nikes are really expensive. I'm going to get some Kessies instead. They're just as good. And
Right.
But that's what they do with food all the time. They say, well, I'll just get this just cheaper brand. There's no difference.
Yeah.
Food needs to become, you know, part of the regular lexicon so that people can understand the choices that they're making. They don't understand the choices that they're making because they're not being told.
Well, you know, as I've aged, I've come to the realization that if I have $100 to spend on food, I'm going to spend it on good food. It's not about getting empty calories. It's
but
about
how
good
long
stuff.
did it take you to get there?
Took me a lot of decades. A lot of decades and a lot of trial and error.
Wouldn't that be great if it started earlier?
But,
yeah.
You know, I mean, the biggest investment one can make is on yourself. That's, to me, your number one investment.
I agree.
And
Yes.
and you know, when it comes to food, that's top 5. You know, and I'm telling people, don't skimp on the food. Look at the ingredients. It's not about price.
If you can't pronounce it, you shouldn't eat it.
Yep.
By the way, I know I shouldn't go there. God help me for this, but I just want to point out that there was no dismissing his concerns, no second guessing, not at least that he mentioned, no gaslighting. He had pain, he got tested, he got diagnosis, and he got.
Oh.
I just want to leave you with that.
He did not get the runaround. Nobody accused him of having anxiety.
2 and 3 doctors. Yes. He didn't get his pain dismissed. He got care. He didn't have to. I'm just saying.
Wow. Yes.
I'm just putting that out there. That's my little mic drop. Ooh. And I'm sorry to do this, but I just wanted to take this opportunity to just point that out. God help me, because I know this is not like the time, but I do, you know, wish him well, and I'm really glad that he did this. All right, so let's take a break and we'll be right back. And we're back. So we were talking about food supply and prevalence of illness as a result of, well, we were talking about so the article was actually on the rise in colorectal cancers in young people. And then we began talking about the fact that people are just not educated about food. But what about people who, educated or not educated, just simply don't have the means to provide themselves with healthy, fresh food?
or
such as the chronically, such as the unhoused or the housing insecure.
right.
That population, I mean, I don't even know what to say. I had an interview with Jacob Hochberg, who's a health data scientist, and he gave me some startling information about some diseases in terms of, so the diabetes rate is higher, the congestive heart failure rate is higher among the housing insecure. It's just a really, really sad situation. And I wonder if they're getting the medical care that they need, if the rates of cancers among those people, because let's face it, you have to have insurance in order to have a colonoscopy. Are these people getting the care that they need?
They can't possibly be getting regular health care when they need it. They can't possibly be getting, unprocessed food on a regular basis. They can't possibly be getting that. How would they be getting that unless you have reliable shelter and sort of within a community? Who's following up? How does that work?
Yeah.
Well,
and they have no stove most of the time. They have no refrigerator. They're living either from couch to couch, or they're just living, under some bridge somewhere or some encampment. If they're lucky enough to own what do you call those things that people go camping with?
Oh, like a sterno, or like one of those like little, like a portable, you mean a tent? Or do you mean
a tent thing?
Oh,
yeah. You can tell me
I can tell you're used to roughing it.
Yeah, that's right. I go camping all the time.
Yeah.
No, actually I don't. But yeah, so if they're lucky enough to even have a tent, where are they going to store food? For perishable food, you have to have some sort of storage.
Well, let's look at the data. I like to look
and
at
they're probably
data.
looking at like calorically dense food to carry them from time to time, right? They're not like
processed food that's portable and cheap and available.
I've never been homeless. I think they just
my gosh,
something to fill their belly for the day.
Exactly.
But and whatever it is, it is. But let's look at the data a little bit. We all romanticize the days of cavemen. I guess some of us do, and living out in the West and out in a
Are
shack.
you taking a knock at paleo?
No, I'm not taking a knock at that. What I'm saying is that if we look at the data and life expectancies based on graves and based on data that we found, our ancestors going back millennia, their life expectancy was 30 years, 30, 40 years.
Wow. Yeah. They procreated really early, and then they pretty much dropped dead not too long after that.
And then,
but it wasn't because of chronic illness. It was because they were being chased by some beasts. Or they got crushed, or they fell to their death.
Some of them, yes, but
they had to die. They didn't get old.
Whether they were in cities,
they didn't prematurely die.
They didn't necessarily have chronic illnesses.
That's what I'm saying.
Well,
they died. They just died young.
I think that that death of that young death,
and it would be probably something as simple as they got injured by a spear and then the infection killed them.
You're going into Cecil B. DeMille land where everybody.
No, I'm not going into.
I think more people would die of natural causes.
You went back to caveman days, so let's
move forward to
the agricultural.
The Industrial Revolution.
Okay, the Industrial Revolution.
Early 1900s, the life expectancy was about 50 years, and no bears were roaming New York City. Maybe a horse, but not a bear. Anyway, the thing is that the compilation or aggregation, not aggravation, but aggregation of unhealthy living. If you take the childhood diseases that were not treated, then you subject the body to a lot of things and a lot of diseases that we've eradicated right now. The inability to get any health care, the inability to be warm at night. You start adding these things, the mental stress that must come with being homeless. All of those things, if you add them all together, they have to take years away from your life.
Oh, yes.
For sure.
Yes.
For sure.
Let's add it together. I mean, You know, like we now.
So why didn't you just say poverty?
Well, I had to start somewhere.
Well, I guess also we're defining the different ways that poverty presents, I guess, that, you know, it's how what it does to you, I suppose. I mean, it's got to be so stressful. I don't see how you can't have diabetes and heart condition if you're homeless.
Yeah. The other day, I was carrying some furniture around, and the next day, I wasn't feeling well. I'm not saying I was sick, but I wasn't feeling 100%.
You weren't feeling your best.
And that was just carrying two things around and me being woe is me. Can you imagine feeling like that every day and every day?
Yeah, or when you just get a lousy night's sleep. When you get a lousy night's sleep, or you sleep on, like, if you slept on the floor instead of on the couch or on your bed, you know you don't feel as good. You're not functioning.
Yeah, or it starts raining at 3 a.m. And when we hear the thunder or the rain, we wake up and we roll over and blah, blah, blah. Can you imagine that stuff is coming on your head? Yeah, you know, or a honking horn or whatever, waking you up, or some dude trying to steal your shoes. So I gotta say that the cumulative stress of being in that kind of condition can get to you. And now we're starting to just look at the science of that and how that just permeates into it. I don't know, Jackie, maybe your college days, you had those experiences, where, you were out all night and
yes, I remember those days. I remember showing up to work the next day and, not grumbling, but I certainly wasn't 100%. I've been camping before. I can't believe anybody camps on purpose. It's so like, you're shot the next day. The ground is hard, like, oh my God.
Yeah, exactly. Like, there's, and now, for the first time, and I'm really excited to be able to listen to this interview, is that, for the first time, we're starting to put some science on this and say, hey, if this is your condition, you can expect to live Y amount less years in your life. So that's kind of interesting, and it's kind of good.
Well, the goal of the data, according to Mr. Hochberg, is to get city agencies involved in providing care for these individuals, getting them, from the beginning, whatever the beginning is, and immediately pairing them up with healthcare providers, a nurse, to sort of walk them through, to just have some sort of system in place to catch them so they don't fall through and die from these chronic illnesses, so that these illnesses can be managed on some level, get them regular care. Look, you and I, we go to the doctor, for example, and the doctor says, come back in 6 months or come back in 3 months because I want to check your blood work again. They don't have that. They don't have that luxury of being able to.
They don't know where they're going to be in 3 months.
They don't even have no idea where they're going to be in 3 months. So a system like this that would give them some hope of some semblance of normalcy in terms of care would be what the goal is of this data. So let's take a listen to my interview with Jacob Hochberg.
Sounds good.
All right.
I'm speaking with Jacob Hochberg, Executive Director of Customer Insights at Arcadia, a population health data company. He's here to talk with Urban Health today about the link between housing insecurity and chronic illness. Thanks for talking with me today.
Yeah, thanks for having me.
All right, let's get started. So tell us about your background.
Sure. So I spent 7 years at Steward Healthcare Network, which is a large ACO in the Northeast. Started in the very early days of value-based care as a data analyst. And in my time there, I worked closely with care managers to help build out care management programs and evaluate the effectiveness of those programs. I also did a lot of ad hoc analytics into, what are the next opportunities to look at? Where should we invest resources to build value for Steward and in the communities we serve? After that, I came over to Arcadia and started the customer insights team. Been here for about 3 years, and we work with our customers to do ad hoc analytics and also help them look for value opportunities and proactively give our customers information on where they might be able to effectively help their patients.
So what was the impetus for doing this research?
Yeah, absolutely. So when I was at Steward, we always wanted to build out a program around social determinants of health. And we had a lot of challenges identifying the right patients. And then because we couldn't identify patients that we could support with these programs, we couldn't justify the investment. And we always kind of were stuck in this cycle where we couldn't invest enough to identify the right patients. And as a result, we couldn't run programs effectively or even build programs and fund them. So about 2 years ago at Arcadia, an analyst and I really started digging into all of the data we had to see if we could find better ways to identify patients with various social concerns like housing insecurity, food insecurity, social adversity. And we built out a mechanism to identify a larger number of patients than you otherwise could using kind of standard methods of just looking in claims or clinical data. After we built out this process, we suddenly were able to identify a larger number of homeless patients than we otherwise would have been. So for instance, back in my Steward days, we were usually doing analysis on maybe 30, 40 patients we identified as homeless. Here we were able to identify about 2,500 patients for our study. Wow. Who were housing insecure in Medicaid populations. And then we were able to start to compare them to other members in Medicaid populations. And that's where the results really kind of shocked me personally. And that's where we really dug in and did a bunch of analysis to try and bring some of these trends to light. And
what was your methodology?
Yeah, absolutely. So we looked for, there are a few different components. So the first piece was, how do we identify people? So that was, there's specific codes that are billed on an insurance claim that can be used to identify a patient as homeless. They're not used very frequently, but when they are used, they're effective. So we use those codes. We looked in EHR systems for assessments that were done. So if a patient was asked, how many times did you have a place to sleep this month? If they said, less than 5 nights they had somewhere to sleep, then we could flag them as homeless through that assessment. We also have a care management tool. We were able to really look at patients who were screened by care managers using our product with similar questions and answers and identify patients as homeless. Once we built out that base of the identified population, then methodology-wise, we compared the homeless population to the non-homeless population in Medicaid contracts in our system. So we're really doing an apples to apples comparison of adults in Medicaid contracts who were not flagged as housing insecure versus those that were.
So is housing insecure and homeless, are they the same category? Because I think of housing insecure as sometimes they can couch surf. Am I thinking about that wrong?
No, that's definitely the right way to think about it. So the study we have is housing insecure and homelessness. So patients specifically identified as homeless, we count as housing insecure as well. But there are people who did not have a comfortable place to sleep or a steady home in a month. We would count that as well if they're couch surfing. And from some of the assessments we've seen, there's some middle ground as well where people couch surf for part of the month and they have nowhere to stay for part of the month.
So if you could give our listeners a general overview of the results, that would be fantastic.
Yeah, absolutely. So we saw a few things and there was kind of what we expected to see than what we actually saw. And the primary thing that really stood out to us was just how much more chronically ill the homeless or housing insecure population was than the rest of the Medicaid population. So for instance, 35% of the 2,500 housing insecure members we looked at had chronic congestive heart failure. That's 21 times more than the rest of the Medicaid population. 22% of these patients had diabetes. So it's 1 in 5 housing insecure patients had diabetes. Again, 5 times more than the rest of the Medicaid population. 21% had chronic acute renal failure, and 22% had congestive chronic obstructive pulmonary disorder. So, and that was 8 times more than the rest of the population. So these are really severe chronic illnesses that are where the prevalence is really quite high.
So why is diabetes 5 times more prevalent for housing insecure individuals?
My theory there would be if you don't have access to housing, you probably also don't have access to nutritious meals. You may often be food insecure as well, meaning you're not able to manage your diabetes. You're not able to avoid the more chronic illness of diabetes. you're probably not getting identified as pre-diabetic and having that opportunity to stop the progression as well.
So you said people without proper housing are 21 times more likely to have congestive heart failure. Why is that?
Yeah, I think so. Congestive heart failure is often much more prevalent in seniors. So I think for the Medicaid populations that we were looking at, congestive heart failure is not very prevalent at all. I think it's about 4%. And then when you're looking at the homeless population, it's all the way up at 35%. So that 21x increase is because the prevalence is quite low for a Medicaid population because typically they're under 65. And then for the housing insecure population, their chronic disease burden is much closer to a Medicare population or seniors than their age would suggest.
Were you able to measure over time how long it's kind of chicken and egg, but the housing insecurity or the chronic illness, do they run alongside each other, or did one predate the other?
So we weren't able to make that inference in the data we have. In theory, there have been other studies that show based on upbringing, based on certain factors throughout your life, you become much more likely or predisposed to chronic illness. So it's likely that some patients were on the path to severe chronic illness before they became housing insecure. Some patients may have even become housing insecure because of the cost of those chronic illnesses, but we can't specifically say without speculating.
So what did you see in the data that led to your conclusion?
Yeah, so for the chronic disease burden, we have the ability to just calculate prevalence rates and look at the patients who weren't housing insecure versus those who were. But it was also backed up by the cost. So one thing that we saw was from a cost perspective, the housing insecure population also, not just did they have indicators of disease that were more significant than the rest of the Medicaid population, they also spent a lot more than the rest of the Medicaid population. Significant spend, especially in the ER. So a lot of patients were going to the ER and subsequently admitted. And the actual stat I could throw out there is that patients who are housing insecure spend $536 more per month than the non-housing insecure population on admissions to a hospital that began in the ER. So patients presented in the ER and being admitted. So we saw the cost, and then we saw the disease burden on the other side.
So I wonder, what recommendations would you make to help stem the tide of this state of affairs?
I think there's a few important things. I think that with the right level of investment, I think when I think about the cost differentials for the housing insecure population versus the non-housing insecure population, to me, that's actually a real opportunity and a funding mechanism where there's now an incentive to intervene with social and health resources with housing insecure patients. And it can be funded through reducing that medical expense that the Medicaid or that the state has to pay through Medicaid anyway. So that's one thing that I think about when I look at these results, and that's the funding mechanism, and that there's an incentive to justify investment. Additionally, I think given that the housing insecure population has such a high disease burden, I think it's really important that there's better coordination between the health systems and the social resources, so that there's patients are being taken care of from a housing perspective while also being managed from a health perspective. And I think if those are coordinated, that could improve this issue.
So what does that look like in a real world setting?
Yeah, so some programs that I've seen people run is putting a care manager, so a registered nurse, partnering them with the patient as their care manager, while also connecting patients to social workers and local area support systems. So not doing those two things separate, where maybe you try and put a care manager with a patient, and then you also try and direct them to social services in the area, but instead coordinating that through health systems. I think that could be one way to improve and really impact patients.
did you have any demographic information on the population that you studied?
We didn't look at the high level demographics. What we can say is that, typically most of the patients who were identified as housing insecure in our study were in urban areas, primarily on the East and West Coast.
At what point do you think social services interventions would be appropriate for this population?
Now, and probably a long time ago. I think that early intervention is key, especially when I see some of the conditions patients have in this population. It might be, in some cases, almost too late. So I would say early intervention is key. I think ideally patients are identified before they develop congestive heart failure or end-stage renal disease and managed earlier. But I would say if a patient is identified now who's housing insecure and severely ill, it's not too late to intervene. So I'd say now is the right time, but earlier would have been a better time.
Earlier meaning as soon as they were discovered, as soon as an intake was done.
That's correct. Or better screening for poverty and the things that lead to housing insecurity as well, with earlier intervention and opportunities to connect patients to community resources.
Did you see any changes either up or down as far as the pandemic? What kind of impact did the pandemic have on this data?
Yeah, so from a housing insecurity perspective, we did not see a major shift, but part of the issue is I think that, in data, there are still a lot of patients who are housing insecure that are not identified. What we did see was a major increase in employment insecurity. So that's one of the things that we are using ICD codes and assessments to map for. And we saw a significant increase in the number of patients we identified with employment insecurity after the start of the pandemic than pre-pandemic.
I wonder how much of that employment insecurity is because of the chronic illness, though. Did you take a look at any of that, or was that not part of the?
So we didn't look at chronic illness for patients who had employment insecurity. The spend was higher for patients with employment insecurity. And generally speaking, Medicare spend is higher in underserved communities, and that's where there's more likely to be employment insecurity.
Okay, do you foresee any reduction or returns to baseline, for lack of a better term, as the pandemic subsides, or do you think this is just going to continue to escalate?
I think the disease burden of housing insecure patients has always been an issue, and I don't see that changing when the pandemic goes away or improves, we'll say. What I would hope is, I think a lot of patients were likely, or people were likely impacted by the pandemic, and that may increase rates of housing and food insecurity and employment insecurity. Optimistically, my hope is that after the pandemic recedes, we will stop having that increase and get back to baseline. But there probably are a large number of people who have been significantly impacted by the pandemic and may have challenges for years to come as a result of 2 years of not having access to certain types of food and maybe not having the same access to clinical support as well, since there were periods of the pandemic where you were not as able to walk into clinics and get the help that some patients likely needed.
This is wow. This is I mean, I don't even know what to say. And then I worry about people falling through the cracks. Like there were, you were able to get a lot of people for this study. I worry about the people who are just like extremely on the margins, who don't even have access to resources like what you guys put together.
Absolutely.
Yeah.
That's always our goal, is to get better at identifying the patients who fall through the cracks. Unfortunately, one challenge we always have is when patients aren't utilizing healthcare at all, we have even less information. And if you're not utilizing healthcare, if you're not utilizing social services, if you're housing insecure, it's very hard to identify patients with those challenges. So the hope is that as we improve, we can identify more and more people and help those people.
Also to help to provide this data to local governments so that this data is actionable, so that some sort of plan is put in place. Is that part of the goal?
Absolutely. I think the justification of investment is a big part of why we built this, but why we're also doing this analysis is to put out there that this is not, there is a social cost on the healthcare side for patients who are not being cared for with community resources. So if we can help patients get access to the right community resources, we can reduce medical spend, and that's how we can fund those programs. So my hope is that with some of this analysis, we're able to better justify investment in social programs at the state and federal level, as well as through some of the new contracts in healthcare. So part of the value-based care space is giving health entities, for lack of a better term, a reason to better support their patients and a financial incentive to reduce the healthcare spend of their populations. So my hope is this analysis will help health systems that are closer to the patients invest, help states invest through better Medicaid programs, and help the federal government invest. I know with the new Medicare program, there's some called ACO REACH. There are health equity benchmarks and components that can hopefully spur further investment in the space.
So what studies are you planning for the future?
Yeah, I think so. We've done the groundwork for the identification piece. We've dug in deep on the homelessness side. Our next step is to dig into other specific social categories and see if we can identify different trends and identify better methods of partnering patients with community resources. So right now we're in the state of identify patients, try and support our customers in building out programs. The next step is once those programs are live, operational, and we now have patients that have had interventions, can we build the right algorithms to, or can we do the right analysis to do two things? One, prove out that those interventions worked, and then two, better identify patients earlier. So our data science team is always working on building what we call our impact ecosystem, which is a series of algorithms that identify patients who are most likely to be impacted by a certain type of intervention. So we're trying to build out our algorithm now that would identify a patient who, with the right combination of a registered nurse and community resources, could be very impactable from a health perspective. So the patients that might be on their way to severe disease, but have not quite gotten there yet.
Wow. Well, thank you so much for sharing this data. This is really important work you guys are doing. I hope you'll come back and talk about further data sets that you guys are doing, because this is really urgent and really pressing for the medical community and
Absolutely.
the health community to be aware of.
Yeah. Thanks for giving me the opportunity to come here and speak about some of this.
Jacob Hochberg, thank you very much for your time today.
All right, thank you.
Thanks for listening to Urban Health Weekly today. I hope you'll join me and my friends next week so you can stay informed and inspired to take control of your health. See you next time.